Welcome to this session entitled Tricuspid Valve Interventions. My name is Anita Asgar from Montreal, Canada. I have the pleasure to be doing this session with Maurizio Taramasso. And we've got an excellent panel and an excellent program for you. You can see our learning objectives. We're going to learn more about anatomical factors that contribute to tricuspid valve complexity and choice of treatment. We'll also share tips and tricks that influence procedural strategy. And we're going to hear some of the latest clinical data. So I'll start with a brief presentation by Francesco, who's going to speak to us about the PCR Tricuspid Focus Group.
PCR Focus Group, for those few of you who don't know what it is a international collaboration program which is putting together more than 70 experts coming from all over the world. We have experts from both sides of the ocean. And we have been focusing on improving outcomes and understanding tricuspid disease in an era, which is already 3 years ago, when there was still a lot of uncertainty, a lot of debate on the general concept. So the main objective, here are the slides, the main objective of this focus group has been to find alignment on these debated concepts. And here now we are in the phase of disease awareness, so we are dedicated to distribute and disseminate the knowledge that we've been collecting these years. And basically, just quickly, I want to share with you what the PCR Tricuspid Focus Group has done in the last year. We have been producing a number of educational events, including seminars and webinars. We published, I think, a very important paper on the state-of-the-art for tricuspid interventions, which is very often used as a reference to other publications, but also to guide procedures and decision-making. And we are now working on the next programs, next projects, which again include seminars, webinar series, but also local meetings for referring physicians. We will open new regional groups, working groups. So stay tuned, because thanks to the industry support, we bring tricuspid interventions forward. We make sure that we deliver a good service to our patients. And with this, I want to introduce the PCR Focus Group participants who designed this session.
So thank you very much. I just want to make sure we introduce our excellent panel today. We have Philip Lurtz, Marta Sitges, Ralph Stefan van Baarleben, and our procedural analyst, who's Xavi Fresha.
Thank you, Anita. And before moving into the session, I would like just to remember the audience that this is an interactive session. It has been thought to be interactive, so please don't be hesitant to put your question on the app, or even to stand up and put your question if you have any doubt or anything that you want to discuss more in detail. Without further delay, I think we can then move to the first speaker, which is Marta, which is present the case that we are going to discuss.
Thank you, Maurizio. Thank you, Anita. So it's my pleasure to introduce this lady, 83-year-old lady, who had long-standing story of atrial fibrillation, more than 10 years. And she comes now to us with severe fatigue and ascites, with bilateral leg edema. She's already on very high doses of diuretics, as you can see here, 160 per dilastics, eplerenone also. Transthoracic echo shows massive tricuspid regurgitation with moderately enlarged right ventricle, with mild systolic impairment of systolic function. Left heart is fine, normal ejection fraction of the left ventricle, on no other heart valve disease. And these are the results of the right heart catheterization with a large V wave in the right atrium. These are her blood results, normal kidney function, elevated liver enzymes, and normal hemogram. So let me focus on the transesophageal echocardiography. You can see here a 4-chamber view. which gives us a rough idea of what's going on. As you can see here, the right cavities are almost double or much larger than the left. That means that they are at least moderately dilated. There is severe tricuspid regurgitation, and if we go to the gastric view, to the shore axis view, we can see that this is a 4-leaflet tricuspid valve with a septal leaflet here with anterior and posterior segments here. And you can see that there is a central gap, but a large gap in this lady. These are the transesophageal views with the biplane view here, orthogonal views cutting in the mid part of the valve. So we have the aorta here, the posterior aspects here. So we have septal leaflet here. This might be posterior, anterior, we don't know in this view, but here we can see nicely that there is a long septal leaflet, but a little bit restricted in the motion. And also here is the origin of, as said before in the transgastric view, central origin of the jet. So a more detailed view here, where we can see again there is a long septal leaflet, but mildly restricted. And this is the summary of the findings. We said it was a massive tricuspid regurgitation. Orifice area was estimated 70 millimeters square. There was severe annular tricuspid dilatation, 48 millimeters, 4-leaflet tricuspid valve. Coaptation gap as measured in the transgastric was around 10 millimeters, moderate septal leaflet restriction, and dilated right ventricle. So we are facing a lady, 84-year-old, optimal medical therapy, mortality risk with surgery was estimated with these several indices, but particularly with the TRI score, which is specifically designed for tricuspid regurgitation patients, and the mortality risk estimation was 22%. So according to the European guidelines, we had also the option of transcatheter therapy of this lady. And for that, looking at the imaging and the functional anatomy, we had a good transesophageal imaging for guiding. That was important. But we had a large coaptation gap with 4 leaflets, which is a little bit more challenging. A little bit of restriction of the motion of the septal leaflet and severe annular dilatation. So according to this algorithm proposed by the focused tricuspid group of PCR, this lady falls here in between the options of a large gap with mild, moderate tethering of the septal leaflet. So we have all the options here. We have TEER, we have annuloplasty, and we may go also for replacement. Our strategy was to prefer repair versus replacement if we were able to do that. It was complex for TEER because of the size of the gap and also because the mild restriction of the septal leaflet. We screened for annuloplasty, but there was a high risk because of proximity of the RCA. So what we decided was to intensify previously to therapy in our diuretic therapy to decrease a little bit the gap and to facilitate a TIA edge-to-edge repair in this lady. So this is exactly what we did, and I'm going to share with you now the transthoracic images after intensive in-hospital diuretic treatment. This is the previous baseline. This is after intensive treatment. And also want to show you the big change in the inferior vena cava collapse, as you can see here. And now I will share with you the video of the transesophageal just prior to the procedure that's going to be performed by Laura Sanchez.
Now we are showing the TOE that we just repeated now in the cath lab. As you can see, I want to start with the transgastric short axis view just to have a look at the anatomy of this valve. As I was said before, this patient initially have a big gap. So regarding the amount of the gap of the patient and also the anatomy, that as you can see here, it's a 4-leaflet tricuspid valve. You can see here the septal leaflet. This is the anterior leaflet that also have one scallop here. This is the papillary muscle, and we have here a posterior leaflet with 2 segments. P1 and P2. So in this case, with a big annulus, big gap, and a tricuspid valve, we decide at the beginning to also scan the patient for a annuloplasty. But when we performed the CT scan, we found that the right coronary artery was too close to the annulus, so we reevaluate the patient for edge-to-edge therapy. And what we made is that we admit the patient 2 days before the intervention. We put some diuretics and we repeated the echocardiography, and we observed that the amount of the TR and also the gap was smaller than in the screening echo. It's important that you know what is the anatomy of your valve just to do the strategy. In this case, we aim to put a first clip here, probably a WXT 3-clip catching the septal leaflet and also the anterior leaflet, and then a second XTW here in the middle with the first portion of the posterior leaflet and the septal leaflet. I want to also show you more images of the patient. This is a direct 2D where we can see better this scallop in the anterior leaflet. And then an important thing is where to measure the gap of the tricuspid valve. We can do it in two places. One is in the transgastric short axis view. We can make here measurements. Here we can measure the gap among the septal and the posterior leaflet, and also here among the septal and the anterior leaflet. But to be sure that we are not overestimating this gap, we need to do the biplane just to be sure that we are cutting just in the tip of the leaflets and not over the leaflets. The other place that used to be very useful for measurement the gap is the inflow-outflow plane with a biplane. In this case, you can see here in the inflow-outflow view that the TR is mainly central. And when we are screening the echo with the biplane, since the inflow-outflow, we have here the 4-chamber views, and we can cut it along all the coaptation line. You can see here the leaflet that must be the septal and the anterior leaflet, and we can move through the valve trying to see what is the gap. Here in the point that we were seeing the color in the previous image, we can see that here we have the gap. This is another place that we can stop the image and just measure here what is our gap. You can see here that in this case is 6 millimeters. And then we continue making a screening of the valve, and we can see here that there is no big amount of gap. Of course, we can also put color in this place where we measure the gap, and you can see here that the color is mainly from this area.
So maybe we'll start by just asking some questions to our panel. So Marta, maybe you can help us. You did an excellent presentation of this patient, clinical history, imaging. Are there factors or things that you see on the imaging that help you decide how complex is this procedure going to be, and how are we going to choose what's the optimal device for the patient?
Yeah. So first of all, you need good imaging. If you don't see, you don't clip. That was the sentence made by this meeting. So that's the first thing. Secondly, what we need, or what the interventional needs, is tissue to grasp, as the surgeon needs tissue to repair. So we need flexible leaflets, not restricted leaflets, and with enough distance to be grasped. So mainly what we are looking is at the size of the gap. Laura very nicely showed how to measure the gap. And then we look at the restriction or not, particularly of the septal leaflet in the tricuspid valve. So these are the main things that we look at.
So maybe, Philip, I'll ask you the next question. You know, this patient responded very well to prehab, as we call it, where a patient gets admitted, quite intensive diuresis. Some people are actually doing dialysis or hemofiltration. How do you choose what type of therapy and what type of patient requires this kind of therapy intensification prior to intervention?
I love your case because I think there's so many features involved which are relevant. Typical age, normal LV function. The majority of patients we see with massive or torrential TR, they actually have normal LV function. I'm pretty sure that she has some sort of left ventricular diastolic dysfunction. So HFpEF and TR is a very common combination. We have a large gap but we have only mild to moderate tethering. So normally when we create these boxes of patients, we put large gap and severe tethering in the same box. But this is also a quite common scenario of large gap, but not so much tethering. And these are the patients, in my experience, which actually benefit a lot from prehab. They respond to diuresis, and in those you can reduce the gap. And it's so important because when you look at the patient initially, you will think that he doesn't qualify for any appropriate therapy, and then you do a bit of diuresis, and it's a completely different scenario.
So what would be the downside of bringing in patients with severe tethering and trying this strategy? Do you see a downside?
Well, once you have a certain degree of tethering and right ventricular remodeling, normally diuresis doesn't do the job.
Okay. And so, Stefan, we've seen some improvements in the anatomy after this intensive prehab. Would that change your clipping strategy or your procedural strategy?
We now have modern devices. So one change that we've seen over the time course of the last 4 years is that we go more and more central, less commissural. With the early devices, we only had arm lengths of about 9 millimeters. We're moving more and more to 12 millimeters. We have a wingspan of about 26, 28 millimeters. So we can overcome the sizes. And if I've seen this, I think it's very important that atrial forms of tricuspid regurgitation are much more common than the mitral space. So we're not talking about 10 to 15%. In these cases, above 75 or 80 years of age with long-term atrial fibrillation, we're talking about 35% of the patients that do not have the classical textbook appearance of just a ventricular dilatation, but they have annular dilatation by atrial dilatation, which has 2 or 3 aspects that are important. Once they still react on diuresis, this is a good predictor that also TEER will work because the annular dilatation forces are less. And if your dilatation comes from the atrium, the forces are much less than if you have MAC on the mitral or if you have large bore arterial hypertension. The pressures were low. They were below 40 millimeters mercury. So these annulus and these leaflets react on a TEER procedure, even though the leaflets are thin. In the beginning, in 2015, we thought we would TEER the leaflets of the tricuspid valve because they're so thin. But they withstand this TEER procedures, and we get excellent results in those patients. So I think this is a sweet spot. And those atrial enlargements are so large that actually ablation is not successful anymore. You don't get these patients into sinus rhythm. 90% of these patients have atrial fibrillation, and so it's important to address these valves, and they will remodel. They will remodel by the ventricle, which is still good in its systolic function, and they will remodel by the atrium. Perhaps a little less on the atrium, more on the ventricle.
Okay, well, maybe we'll go and we'll show the rest of your case, Javi.
Well, thanks just for being here. So this is the hospital clinic team, as you can see. Special thanks, to the organization for letting us, the opportunity to be presenting. Dr. Reguilón and Dr. Laura Sanchez are here, and Dr. Sanchez was behind the scenes. So you're going to present this case kind of step by step, but focusing on the points that we consider more important. So here you can see the advancement of the system of the guiding catheter. As you know, it's a 24 French catheter that we just apply the minus just to be straight, but we always like just to advance, with this spoon shape to avoid any complication and the use of a stiff wire. Here you see, the insertion in the stabilizer, and in a sense, you have to consider that the system, has a curve, and that curve, if it points posterior, it will point towards the septum. So that's something that you need to take into account in order just to advance the clip and just turn. As you can see here, that would be the default position where you have the blue line, and you can see on the echo on the upper left side that if we turn, that curve will face down. So when we're advancing the clip, when we're applying some plus, the clip, it's not gonna go towards the septum. So here you can see the advancement of the clip. You know that you need to align. You have this blue line, so it's really important. Otherwise, the knobs are not gonna work properly. And here, once you advance, you see that you have to have the tip of the guiding catheter really controlled. So here you can see that it's not advancing As you can see, it's pointing towards the septum because, as I told you, like it's posterior, so it's not turned yet. So in our institution, instead of advancing, we would like just to keep the position of the clip and then pull back from the stabilizer, as you can see. It's also really useful, the fluoroscopy imaging that you can see on the bottom left, to know that you are like facing and you are like orientating the clip in the right position. As you know, the tricuspid valve would be on the right side of the screen, and this is like anteroposterior. There's no turn and no degrees in the fluoro. Here you can see that you need to see always the tip of the clip, as you can see on the echo. And once you do the straddle, you start just to apply some flex. At this point that you deflect, you're away from the septum. Now you have to focus on perfect alignment. And perfect alignment means that in the inflow-outflow and also in the long axis, you need to be completely straight. To start with, again, for me and in our center, we use a lot the fluoroscopy because, as you know, at the end, it needs to point horizontal. If you go to the center, a little bit up if it goes anterior and a little bit down if it goes posterior. But that would be a default position. And the other thing that you can see here, it's what happens most of the times. Most of the time happens that because of the cava vein, it's pointing towards the septum, like the catheter, comes, what we call a septal heart, comes from the septum. So we have this super knob that it's like the septal lateral that actually, as you can see, we're applying, and it's in the guiding catheter, and it gets away that catheter from the septum. So now you can see that from in the left side, the inflow-outflow and the long axis, the alignment, like the approach to the valve, it's good. Another thing that we use, in terms of fluoroscopy, we try just to make, the clip completely, like horizontal and from like side, to see that you see it from the side. So in general, like 90% I would say of the times, and when you open it, you see that you can see both arms. Then you check, as you saw, the grippers, you check, the individual line of the grippers, that there is a point. With this new generation, you have the feature, you have the ability to move the grippers individually. So this is something that we might see, like in the case, but it's something that is really useful for tricuspid especially. And here you can see that we are, once we check, as Laura said, the anteroseptal position in the transgastric view, we advance really careful. So we did this orientation outside of the valve because we don't want to turn too much inside the ventricle to avoid all this cord interference. But it's true that sometimes when we advance, there is some rotation. We try to correct while we're advancing, but when we open, we can do mild rotations. Here you see that it's maybe turned too much clockwise. We need to turn a little bit clockwise. And then it's, the grasping time. I like, like this explained view where we see, like the inflow-outflow and the grasping view, where you can see that the septal leaflet here up, it's clearly sitting over the arm of the triclip, and then like the anterior probably. But there's no rush. Here we're gonna check, like before closing. Here we close a little bit, and that the orientation is good. It's a procedure that you don't have to rush at all. You can check anytime, and once you're sure here that you can see that the lateral, in this case anterior leaflet, it's in, you can close it. And actually, you can appreciate a really nice reduction, like in the position and that we anticipate. And what is better, it's, like we're following the plan, no? So in that sense, we're happy. Another important point, it's, you will see that I'm advancing to release that tension, to restore the coaptation level. And here it's a transgastric view that it's super crucial in this intervention, where you can see that there is like a nice bridge between the anterior and the septal leaflet. It's what we wanted. And we're really close to the commissure. So it's true that maybe you can just push it a little bit more central, but I think it's what we wanted. And now you can appreciate here that there is still a gap. Maybe not that much color, but still a gap. So as Stefan, Marta, and Philip said, it's really important in those cases, more than, like stay focused on the color, you try to restore from the anatomical perspective. And don't forget, from where we come, that it was like a large gap. Remember, 10 millimeter, 11 millimeter gap. So it's something that probably we will need just to treat. So then, we were happy. I mean, we're following still the plan. And now you see that we're releasing the clip. If we got, that coaxiality, that perfect axial alignment, you'll see that the release of the clip, it's completely predictable. You can see here, it's releasing, and like the clip, it's not moving, it's not turning. So that's the objective, of getting, such a perfect coaxiality and such a perfect predictability, in a sense. So we're super good in terms of color reduction, and what is more important, we're super good in terms of planning. So now we remove it and we check again, like here in the transgastric, without, like the interference, that sometimes that happens of the clip itself. And now you can still appreciate, in the middle, between the posterior and the septal, that there's still a gap. So that's the end of the first part.
Excellent. So that's a beautiful case so far. You're making it look too easy. Maybe you can talk a little bit for us about, what are the key procedural steps? How can you set yourself up for success? What do you feel are the most critical parts of the procedure?
We have the smart screen that I think that it's going to be very, very useful. And actually, I'm going to be, in a sense, repeating, but I'm repeating in purpose because, like I consider so much important what we're saying. So, two things really important, and I say like axial alignment to be in this axis, inflow, outflow, and in this axis, long view. So what we do to get this? So we have like these knobs. So in the inflow, outflow, we have two movements. Imagine that the clip is like that. So we have to move it to this direction. We have the flex and the plus. With the flex, it's more direct. It's going to be like this. With the plus, we're going to do the same, and we're going to lose height. With the extension and the minus, we're going to gain height, and with the extension, we're going to do the opposite. Plus, imagine that the orientation is good, but we want just to be more central, like this. So in this case, we use a stabilizer. If we pull back from the stabilizer, we'll go to the posterior. If we push, we're going to go anterior. And then it's the long axis that actually, as I told you, because of the cava, the catheter will come this direction, most of the times. So that was really a pain in the past because we didn't have this thing, But now that we have this thing, with applying L, we're going to get, this direction. And actually, when we're grasping, imagine that you have like a restricted septal or whatever, with small movements, like with the guiding catheter clockwise and counterclockwise, we can go more septal or lateral. And Anita, again, and that's the second point that I think that it's important because we have that valve, and I would like just to thank Daniel because this is homemade. This is our valve, draw. So, but this is the real thing. We have the anterior P1, P2. What makes the difference between anterior and posterior is the most papillary muscle and septal. It's that it's probably the best view to plan the intervention. In this case, we did this. And we got a massive, well, I would say not a massive, but I get a very relevant reduction of the TR. And maybe there's no color, but there's still a gap. So we need to keep in mind that this is not done. The job has not been done yet, so we need to complete. And last concept, but really important, that if we're planning to do more than one clip, we need to go anterior to posterior, because otherwise, the posterior clip will mask all the anteriors. So it's important just to start always from the anterior commissure to the posterior commissure.
Maybe we'll just ask our panel. I'll start with Stefan. What would be your strategy for your next clip? I mean, we're all assuming we're going to do another clip. What clip would you choose? Where would you put it?
I think we started with an XCW, which was highly effective, and we've seen that just adjacent posterior to this clip, we have another regurgitation. We've also seen that it extends a little bit into the P1 leaflet, so a clover technique would most probably the preferred technique. But there's also the possibility to prolong this first clip on the anterior septal, because we've seen that this first was so highly effective that there still was room, and you can also indirectly close this by adapting even more centrally to the papillary muscle with a second clip, actually prolong this anteroseptal connection. And this also has some advantages. The advantages there are that you leave the smaller posterior leaflets untouched. You have a higher opening orifice for the leaflet and easier access for temporary pacemakers, etc. So just not to lose it out of the context, I think the primary approach would be Clover for me here. But the other possibility, if the anterior leaflet is more dominant, is also to be kept in mind as a second alternative.
And so would you choose another XTW? That would be...
Always, yeah. I'm now using, we switched, we started with NT clips, we went over to XT, but actually the brackets, the side brackets, the nitinol, are so nicely to adapt and also to close the anterior-posterior dehiscence that my preferred device in 80% is an XTW, the second choice is XT, and I only have, for some secret reasons, one single NTW in my backlog. I never use it. I exchange it every half a year with Abbott, but I predominantly use XTWs, and you can almost always implant them. Just for reasons, if you go between two clips or you have to do redo, an XT is also a very powerful solution if you sometimes only want 4 millimeters, and then you use them as a second alternative.
Any other thoughts, Philip? Anything you would do differently?
I probably would place the second one anteroseptal as well, but that's operator's preference. But what I guess is important to recapitulate is the fact that we call it tear, but maybe it's not the right term, because what we do is not just edge to edge, but we cause a large coaptation. And what it does is not just treating the leaflet, but ideally we pull over the RV free wall towards the septum. So we get sort of an annuloplasty effect for free. And this is the reason why we see less TR away from the site where we implanted the clip. And that's the fundamental principle of the therapy. And this is why I prefer to close off the anteroseptal commissure, get that indirect annuloplasty effect as much as possible, but still maintain the motion and opening of the posterior leaflet.
And we have one question from the chat from the audience that I would like to ask Marta regarding the role of 3D echo, specifically before closing the clip. I think probably to check the orientation of the clip. Do you rely on this? Do you use it? What's your opinion?
We use it, but unfortunately at the time being, for 3D imaging of a tricuspid valve is still more challenging than a simple short axis that is very, very useful also. So you get more or less the same information with higher quality and quicker. You get faster for the interventionalist.
We have another question, it's not yet there, but maybe before moving on, because we are saying always Clover technique, maybe somebody doesn't know. Clover means basically when it's a surgical technique where at the end you have a triple orifice valve, and if you put the clip between anterior and septal leaflet and then a second clip between posterior and septal leaflet, you will end up with this Clover configuration of the valve with 3 orifices. So this is Clover technique.
Right, so why don't you show us what you did?
Well, actually, we kept on, with a plan, with a plan that, Laura explained at the beginning. It was like, remember, first clip, anteroseptal XTW, and the second one, would be, if it works, posteroseptal, P1 septal, central, XTW as well, to reduce this gap. So here, I would say that, advancing a second clip. Once you have all these, anatomical reference, you have the clip in position, it's much easier. Plus, you also have, and you also know, the right orientation. So again, as you can see, Dr. Regueiro here, it's pulling back from the stabilizer. I keep the position of the clip. Laura, it's checking that we're not interfering with any structure, that we're not damaging anything. And that's why I put, large, like the fluoroscopy, because it's really useful when once you have implanted the first clip, to try to be parallel to this first clip. Try just to replicate, all the knobs and all the turns that you applied. And as you can see here, once you get parallel to the first clip, you check the echo, and most of the times, I would say 80–90%, so you're fine. And here, actually, you can really see that what we were talking in the smart screen about coaxiality, about axial alignment, it's perfect. And actually, what we did is just do the same thing that we did with the first clip. It saves a lot of time. You use, like all the information, and in this case, fluoroscopy. So again, we're going to check, like both gripper lines. You check, like the individual with a pointer, and then we're going to go central. The idea, as Laura told you, would be to go like completely central, P1 or posterior to septal, get as much tissue as possible, and like just try to reduce, like the gap that we had. That maybe now it's not so real, but that patient, had like a large gap. So in this case, we advance. We check, that the orientation was good. When we have a clip, we like to advance, with the clip close. And here you'll see that probably we need some tiny, like clockwise turn, because it's not, like I would say the lateral arm. It's between, like the posterior and the commissure. So we want to ensure that, it's grasping a lot of posterior tissue or leaflet. And, like probably here it's too anterior. We're going to pull back a little bit, you'll see, from the stabilizer to get a more central position. In any case here, we have, like again, no rush. We can check that everything is fine. Here, like it looks that both leaflets are over, like the arms of the clip. Looks like a good position. But again, we're going to check again, like in the transgastric before going down, like with the grippers, that the position is actually good, and we don't need to do this, like a small turn. Here it looks like reasonable. It's completely horizontal from 9 to 3. It looks like we're grasping, like all the posterior. And now you'll see that, both leaflets look in, like clearly the septal's in. Maybe the posterior it's not that clear, but like the orientation was good, so we're going down. We close 60, then we ask for the color, and we will see the reduction. And something, in the fluoro, if you appreciate, something is happening when we close that, well, the color reduction, it's kind of good. But when, Dr. Regueiro keeps on, like closing the clip, you see that there is like a clear interaction between the septal arm of the clip and the other septal arm of the first clip. So that's not acceptable. I mean, we had like a very good grasping. We had like a very free, clip there, like working a lot. So we don't want just to spoil that. So we want again, into the ventricle, and we're gonna make like some changes. So again, no rush, no problems. So we don't like just to turn too much, because we don't want just to get, into this court. So we're gonna change a little bit the strategy. So we're gonna counterclock a little bit the clip to try to get rid from the septal arm of the other clip, and in this case, we close. You see that the reduction in the color, it looks good, and apparently there is no interaction with the clip, and that it's like really something that is surprising, because when you check the transgastric, you see that even though you reduce, color with this second clip, the posterior leaflet is gone. So, message, like color reduction, it's not always telling that you have a good grasping, okay? It's just that with a clip, you're stabilizing the septal, so it keeps the septal up, so then the coaptation, it's better, but it's not good. So then, we open the clip again. We're trying, to get, these both leaflets. Here you can see that the septal is in, but not so much in. And here, you'll see that we're closing a little bit, and now looks like a little bit more away from the first clip. And now it say that the result is superb in terms of color reduction. And again, like it's just our job, just to, I would say, evaluate if that's what we're looking. That's enough. That's not enough. So you can see that both leaflets are in, clearly in, especially the posterior. But maybe the septal, I would say that it's not just the tip, but it's maybe not the amount of leaflet that we wanted. Again, we anticipate the future of this lady with all this pressure, with all this gap. And really, we would like just to have like more tissue inside the arm of the clip. So again, we open, for the last time, and then we used, like this unique feature again of the clip of this new generation that it's, the independent grasping. So we optimize the septal arm. We went, like you can see that the posterior is in already because we knew it, and we went just to almost to the annulus, just to the very initial part of the septal leaflet. We go down with the grippers, and now we we close it. And we check the color. And, something again surprising happens. That actually the color result, it's maybe worse now than before. But now we have more tissue. We have what we wanted. It doesn't look, like a lot of tension. So what we do, we're treating color or we're treating anatomy. So in this case, you checked in the transgastric that we decide to treat anatomy. We had like huge tissue inside. We thought that would be like the best thing, like the approach was good. So we decided that was better than before. So we release it. Again, axial alignment, it's good because, when we release it, like it's not moving at all. And what we saw after releasing the second clip is that, what we, like anticipate that, we rather have, this anatomical correction. Now the color, went back, to our, very last grasping. So in a sense, we had this reduction of 3 degrees from massive to, I don't say trace, mild, I don't know, but something between, these 2 degrees. Good grasping, good tissue inside, following our initial plan, and especially, we feel safe that, these clips are going to hold, the future pressures of this coaptation gap. Here you can see that Laura showed, like the initial result or the baseline after, inducing the anesthesia that sometimes goes a little bit down. And then we are, happy with the result. And we always do, like a final check, in the transgastric view. We always check, the gradients, the mean gradients. In this case, was less than 2 millimeters, was 1.4, and that was it. So thank you very much for your attention.
That's an excellent demonstration of patience and persistence to get a spectacular result. So thank you very much.
Thank you.
I'm going to invite Philip Lurtz to come and talk to us now about TriClip TEER latest clinical outcomes.
Thank you. Yes, so I'd like to share with you some results of the BeRight study. What the BeRight study, in my opinion, brings to the field is it provides us with some real-world data. I mean, obviously, when we started, we selected patients very carefully. If we look at the Triluminar trial, these were carefully selected patients. But the BeRight study is a more real-world reflection of what's been treated at the moment, of what results can be expected in a broader and probably also more complex population. So the BeRight study was initiated to evaluate the real-world safety and effectiveness of tricuspid TEER using the TriClip system. The primary endpoint is acute procedural success defined as survival to discharge with successful implantation of the TriClip device, resulting in TR reduction of at least by 1 grade. And the secondary outcome is all-cause mortality or tricuspid valve reintervention and reoperation at 1 year. Patients were considered to be included in that registry when they were symptomatic, obviously, with at least severe TR, and those with severe pulmonary hypertension or concomitant mitral regurgitation were excluded. In the following, I will share with you some 1-year data. 200 patients could have had the 1-year follow-up visit, but out of these patients, some obviously dropped out because of death. 19 subjects have withdrawn the consent. There were follow-up misses of 8, so that leaves us with 151 patients, but unfortunately, and seen with many other studies, obviously this was performed also in the midst of the COVID pandemic. We could do follow-up by telephone only in 29 patients, so we do have echo data of 114 patients. But let's go back to the baseline characteristics of these 200 patients. Typical mean age 78. We have a fair split between a man and women, highly symptomatic patients, more than 80% in NYHA class 3 or 4. What's really striking here, and needs to be acknowledged is the fact that the vast majority of these patients, they presented with a baseline TR grade of massive or torrential. So you see that we treat these patients with massive or torrential TR, so rather late in the natural course of the disease. And then a lot of comorbidities, as always seen, a reasonable number of patients with prior cardiac surgery, and 23% had pacemakers or ICDs, so leads across the tricuspid valve. So that's a very important question, whether you can also treat these patients, and you see that 1/4 of patients had lead across the tricuspid valve. Here you see the safety data at 1 year. At overall, we're 11.5% with major adverse events. Cardiovascular mortality was 8%. I believe this compares very fairly to natural cohort studies, especially if you consider, as said, baseline TR was massive and torrential in most patients, and this differs to the outcome as compared to severe. All-cause mortality 11%. What's need to be added is that major bleeding is a quite common complication in these patients. This has nothing to do with the procedure per se. This is not exercise related, but just a reflection that bleeding risk is increased in these patients with presumed also some liver disease, and then a rate of SLDA of 3%. Now looking at the percentage of patients who ended up with a TR grade of moderate or less, both at discharge at 1 year, and here we see at quite encouraging numbers of 88% at discharge, and that was well maintained throughout follow-up, 86% at 1 year with moderate or less TR. And this was also associated with a positive signal in terms of remodeling, smaller tricuspid valve annulus, and also smaller right ventricle. And as expected, and here confirmed, this is associated with a clear signal in terms of symptomatic benefit, better NYHA class, better quality of life. And if we compare the rate of heart failure hospitalization in the year before the procedure with the year after the therapy, we see a 44% reduction in heart failure hospitalization. What are we aiming for? Here you can see 2 Kaplan-Meier curves comparing patients who ended up with severe TR as compared to those with moderate or less, and you see obviously moderate or less, much better outcome. So that should be the treatment goal in 2022 when treating TR, moderate or less, much better outcome. Most patients were treated for this 1-year analysis with the G3 device, but as you've seen, there's obviously also the G4 tri-clip system now allowing to do independent grasping. And if we, there will be a more detailed analysis this afternoon comparing G3 with G4, but just 2 remarks. One is, it appears that with G4 we treat quite complex anatomies. So if you look at number of leaflets, more than 1/3 of patients had a sort of non-standard tricuspid valve, so more than 3 leaflets, as also seen in the case today. And then 2/3 of patients had a gap of equal or more than 7 millimeters. So of course we always say that 7 millimeter is some sort of threshold, but the real world reflection is slightly different. Same safety profile between Gen 3 and Gen 4, similar implantation success and timing. But what's quite interesting, and we have to analyze that in a little bit more detail, it seems that the rate, if you want to be even more ambitious, the rate of mild or less TR seems to be higher with the latest generation of the tri-clip device as compared to Gen 3. So again, quite encouraging. So in conclusion, B-Right adds to the field some real-world data. We see that many patients, they seem to present quite late. We treat in the vast majority massive or torrential TR, but yet we get good outcome. We see a quite robust and strong signal in terms of symptomatic improvement, and with G4 we treat quite complex anatomy. Thank you.
Thank you. So if I could ask you just to give us one takeaway from your experience with real-world data with the B-Right registry, what would it be?
It would be that we treat very sick patients who present late and are quite advanced in their stage of disease, but yet we get a very positive and encouraging degree of reduction in TR, looking at more than 80% having less than the moderate TR, which is good. And obviously we went through a certain learning curve, but this is still to some extent early days, isn't it?
Thank you. So Maurizio, we've seen Xavi show us an excellent, taped case, a very complex anatomy, successful repair. We've seen Philip talk to us about what real-world data shows. From your surgical perspective and experience, when we're looking at strategies to treat tricuspid regurgitation, what are your thoughts?
I think the best way is think to physiopathology. I think that there cannot be functional TR without annular dilatation. There will be a different amount of tethering according to the etiology, let's say, leading to TR, but annular dilatation is always present. And I think the strategy that we have seen in the case of Xavier, which really aim to fix the annulus together with bringing together the leaflet and reduce the gap is the way to go. From a surgical perspective, most of the patients are treated with annuloplasty in order to fix the annulus and to force the coaptation, so to fix annular dilatation and to bring the leaflet together exactly as we do with clip. And there is now, of course, an ongoing debate whether we should replace or repair this valve. But from a surgical perspective and a pathophysiological perspective, it makes much more sense to repair this valve if you can repair them. Obviously, we will not be able to repair all of them. There will be also a role for repair, and there is a role for repair as in surgery, but I think repair is still and will remain the gold standard approach from a pathophysiological standpoint.
So in surgery, just to summarize what you've said, in surgery, obviously the first line is repair. We do see lower mortalities with repair in surgery versus replacement.
You replace only if you cannot repair. Exactly.
Right, and so maybe that's where we're going to be headed with transcatheter as well. So I'll invite Stefan to talk to us about interventional management of tricuspid regurgitation, the new frontier.
Thank you, Nita. Thank you, Maurizio. It's my great pleasure to just sum up what we know so far about the interventional management of tricuspid regurgitation. And I think it's a new frontier that we see much better results. And just to remind you, if we take medication to reduce TR, we get a quality improvement of about 4 points. In TR, we see even higher values of KCCQ improvements of more than 20 points. That is the highest value we've ever experienced. It's higher than TAVR and it's higher than mitral valve treatment. These are my conflicts. If we just sum up what we have seen, I want to highlight certain points we already heard by Philip, and we have to highlight that we have a 1-year mortality of 8%. Even the best surgical volumes are at 30 days or in hospital in a range of 6 to 8%, and we show this at 1 year. So I think this is exceptional. The second thing I would like to highlight that we see a much higher efficacy now with the 4th generation of devices and already with the 3rd generation of devices in TriClip that goes to a very high number of 0 and mild regurgitation that we've also seen in the live case. And the all-cause mortality over the time course of 1 year is also exceptionally low. We have to remind ourselves that in the co-op trial, even in the treatment group, the 1-year mortality was at the range of 19%. We've seen that the situation in these patients here is 8%. So it's a clear benefit to the natural course, and also the rehospitalization rates over the range in the Triluminate trial as well as in B-Right are in the range of 40 to 50% reduction. What we also know is that it's important, we've seen it in this case, is to control the septal hugging. And this is a unique point, what we see with the L-knob, that we're able to correctly align to the hinge points of the annulus. If you've seen the B-Right data, 23% of the valves had an annulus diameter of more than 5 centimeters, which is currently almost untreatable by replacement. The second learning we had is that we aim for longer coaptation length. to get the leaflet deeply in. And this has been shown by the 3 attempts nicely in Barcelona, where more and more leaflet in means more efficacy. And this trajects also to the adjacent tissue. And surgeons aim not for 4 millimeters, Maurizio, like in the mitral valve, but also in tricuspid, they aim for 7 to 8 millimeters coaptation. So taking a click bomb length of 8 and 12 millimeters produces 9 to 10 millimeters coaptation to the adjacent tissue. And this is one of the reasons that these new devices are so highly efficient. If we look into these first randomized trials, we get now the results actually of the Triluminate pivotal trial, possibly next year with full enrollment. So we will learn for the first time in a randomized cohort what medical treatment can produce and what additional device therapy will give us as an additional benefit. And this is a group of 450 patients enrolled in a randomized fashion 1-to-1, and we're highly interested to see this result in 1 year's time. What about the other futures? Of course, repair will be the predominant first-line therapy, especially if we have more and more evidence, we will move to earlier stages of the disease. Philip has shown that we're treating those patients rather too late because it's only a 2B recommendation. With the current evidence that we have in randomized trials in the future and in single-arm trials at present, even with a rate of 25% pacemaker leads through the valves, we see excellent results. So my prediction would be, in going more and more early, we will see that repair remains the first-line strategy, but we also have to reflect that in the future we will see different replacement options because there are diseases like carcinoid, Epstein's, etc., where we will not be able to apply TEER nor annuloplasty, and these also have to be kept in mind. That would be my points at the end. Thank you very much for your kind attention.
We have a couple of minutes left. Maybe I'll ask our panel to give us a few final thoughts. I'm going to start with Maurizio. Any final thoughts for this session?
Well, I think the main take-home message is that we have at the moment a great technology which improve also the let's say easy to use for the operator. It has been perceived for many years, and still it is perceived as something that only few really skilled operator can do. Actually, it's becoming less and less true. Obviously, we need good imaging, as Marta showed us at the beginning. But then, as Xavier showed us, we can really predict the trajectory in a really controlled way. So we need where to go and how to reach the trajectory that we want. And then Philip and Stefan showed us that we have already great evidence waiting for randomized control data that the procedure is safe and we can achieve excellent TR reduction, and this has been associated with the improvement of the device. So improved technology will make the procedure easier but also more effective.
Marta, any final thoughts?
I think we are witnessing a complete revolution in the approach of these patients. These are really sick patients that we were not able to treat. Surgery might be very good for selected patients in the very initial, maybe at the time of the left heart valve surgery or very initial stages, but this is not what we see in real world. In real world, we see these patients very sick and we didn't have a solution for them. So now I think we are opening many new fields of advancing in this disease, but for the time being, effectively treating these patients that were no option previously.
One quick question. We did aggressive prehab in this patient. What do you do after when you discharge the patient? How do you manage the diuretics? So Xavi, maybe you want to...
Basically, I think that for the first 3 months, I think that it's, in those cases, I would say you're expecting a remodeling. So I think that it's important to keep almost, I would say, the same regimen, just to avoid, like the enlargement of the ventricle and too much tension on the leaflets. But anyway, in this case, since we were able, I think that to treat, like the anatomy, I think that this patient will do well. But in a sense, even though the patient might feel better, we like just to keep for 3 months, this treatment.
Right. Philip, any final thoughts?
Apart from any intervention, what we start to do is we talk about RV failure, we talk about right ventricular physiology, and it could be of tremendous benefit apart from any intervention. And we finally discuss a huge problem in cardiovascular medicine, which we haven't talked about for the longest.
Okay. Ralph? 10 seconds.
I would just say that it's 10 years of the therapy. The first publication was done in Hamburg in 2012. Actually, it was a single case. The therapy is juvenile. It started 7 years ago. It has adopted and it has much more outreach and much more positive benefits, actually, than everybody anticipated 5 years ago.
Great. So I want to thank my co-moderator, our fantastic panel, the audience, and of course Abbott for sponsoring this session. Thank you very much.
Yeah,